हेलो दोस्तों, कैसे हैं आप सब लोग। आप सभी लोग का एक बार फिर से स्वागत है मेरे यूट्यूब चैनल में। और जो आज का टॉपिक हम डिस्कस करने जा रहे हैं वो है थायराइड एक्टोमी के बारे में, और हाउ वी आर गोइंग टू परफॉर्म सर्जरी फॉर थायराइड एक्टोमी एंड व्हाट आर द कॉम्प्लिकेशंस ऑफ दैट। सो चलिए शुरू करते हैं थायराइड एक्टोमी।
Okay guys, so here we are going to start thyroidectomy. So what is thyroid gland? Thyroid gland is a endocrine gland which is present in our body, and normal weight of thyroid gland is around 20 to 25 gram, and more than 90% of the iodine stored in our thyroid gland. And another information is daily requirement is around 100 to 150 microgram for thyroid gland. And who is the father of thyroid gland surgery is Theodore Kucher is father of thyroid surgery. So what is thyroidectomy? What is thyroidectomy? Thyroidectomy is normally, simply, we can call it as removal of thyroid gland. And mainly thyroid gland is present, located just below the cricoid cartilage. Here is cricoid cartilage, this is thyroid cartilage, this is cricoid cartilage. So location of thyroid gland is just below to cricoid cartilage, and they are at the level of tracheal ring, second, third and fourth, mainly second, third and fourth. So guys, next is types of thyroid surgery. In which we have like hemithyroidectomy, subtotal thyroidectomy, Hartley-Dunhill procedure, and total thyroidectomy, and last one is near total thyroidectomy. So first we will discuss about hemithyroidectomy. In this case of hemithyroidectomy, we are going to remove one lobe plus isthmus. We are going to remove one lobe of thyroid gland and plus isthmus. In case of subtotal thyroidectomy, we are going to removing of whole thyroid tissue, leaving behind only 3 to 4 gram of thyroid tissue in each lobe. 3 to 4 gram, like we can see here 3 to 4 gram, this 3 to 4 gram of thyroid tissue in each lobe superiorly. Okay. And next one is Hartley-Dunhill procedure. In case of Hartley-Dunhill procedure, we are going to perform removal of all but leaving behind only 10 to 15 gram, this green color, 10 to 15 gram thyroid tissue in only one lobe we will left. So this is called as Hartley-Dunhill procedure. Next one is total thyroidectomy. We know by its name, removal of whole thyroid gland, called it as total thyroidectomy. And last one is near total thyroidectomy. In this case, we are going to perform removal of whole gland, leaving small remnant in tracheoesophageal groove, leaving behind small remnant in the tracheoesophageal groove. So friends, here are some conditions in which we are going to perform thyroidectomy. Like in case of total thyroidectomy, we are going to perform when there is thyroid malignancy, in case of benign disorder involving both lobes of the thyroid gland, and in case of hemithyroidectomy, like benign disorders involving only one lobe of thyroid gland. And in case of subtotal thyroidectomy, these are mainly reserved for the patient in which there is no recurrence. is present. Like I can give one example for you. Like in 50 to 70 years back, surgeons were performing subtotal thyroidectomy for the multinodular follicles. But what happened when prolonged follow-up was done for 20 to 30 years, it was seen that there was recurrence from the thyroid remnant. So if remnant is present, then it's very difficult to remove that in second surgery. Why it is like that? Because their anatomical landmarks are lost, and due to excessive fibrosis, it increases the risk of recurrent laryngeal nerve palsy. So nowadays surgeons are performing for multinodular goiter in elderly patients. Elders patient. So here we are going to see procedure for of thyroidectomy and how we are performing surgery in the case of thyroidectomy. So here position of patient in thyroidectomy is roach position या barking dog position. We can see it as like this, and in this case head is up, which is 30 degree, and towel are placed below the shoulder blade. And what is the advantage of roach position या barking dog position? In this case bloodless field occur. And what is the disadvantage of this position, barking dog position या roach position? Disadvantage is it will increase risk of air embolism. So next is we are going to perform Kocher, who is father of thyroid surgery, Theodore Kocher. So we are going to incise Kocher transverse cervical collar incision along skin creases. Okay, and then after that we will place 1 centimeter below cricoid cartilage, and then we will after that subcutaneous tissue and platysma incised sharply, and after that flap is raised superiorly up to thyroid cartilage and inferior till suprasternal notch, and then after that we will strap muscles incised in midline and retracted laterally like this, Okay, so now we can see our patient's thyroid gland. We are going to discuss here some important points about thyroid surgery या thyroidectomy. In this case, whenever we are going to visualize the thyroid, our dissection plane should be close to thyroid. Second point is what is the first structure we are going to like it during the thyroid surgery? So that is middle thyroid vein. Why we will like it first middle thyroid vein? Because it is short. We can see here middle thyroid vein. This is middle thyroid vein, this is superior thyroid vein, and this is inferior thyroid vein. So we are going to like it first middle thyroid vein. Why? Because it is short, and whenever we are performing dissection or retraction, it can get avulsion. So due to this bleeding can leads to bleeding also, can leads to air embolism also. So to prevent this, we are going to first ligate our middle thyroid vein, which is this middle thyroid vein. After that we have to dissect the superior pole. After that we will dissect the superior pole. During this the superior thyroid vessels like superior thyroid artery, superior thyroid vein, this is superior thyroid artery, superior thyroid vein, it should be dissected, skeletonized and ligated individually. Okay, So we have to ligate superior thyroid artery and vein separately. And whenever we are going to ligate superior thyroid artery, then it should be skeletonized, ligated individually and close to thyroid. Why? Because to prevent injury of this external, this one, this, can you see this, to prevent injury of external branch of superior laryngeal nerve. Okay, external branch of superior laryngeal nerve. So we will bind closely to prevent injury of this external branch of superior laryngeal nerve. So last point is about inferior thyroid artery. So inferior thyroid artery should be ligated. Here is inferior thyroid artery, which is the branch of thyrocervical trunk, this is thyrocervical trunk, and this is inferior thyroid artery, which is supplying thyroid gland. So inferior thyroid artery should be ligated close to thyroid to prevent vascular infarction. Why? Because we know inferior thyroid artery is giving branch to the parathyroid artery. Parathyroid artery is a branch of inferior thyroid artery which is supplying parathyroid gland. And if we are going to ligate the inferior thyroid artery away from thyroid, so what will happen? The vascular supply to the parathyroid is also compromised. Okay, so leads to vascular infarction of parathyroid gland. So this is the main reason why patient after thyroid surgery are having hypoparathyroidism due to vascular infarction. So guys, in thyroidectomy we should ligate inferior thyroid artery should be ligated close to thyroid to prevent the vascular infarction of the parathyroid gland. So here we are going to discuss complications of thyroidectomy. In this case, we have first complication is hemorrhage. Why? Due to slippage of ligature from the superior thyroid vessels. Why? Because whenever we are performing the ligazing around superior thyroid vessels, artery and vein, at the time of intubation, patient sometimes having cough, and because of this extensive cough, there is slippage of ligature from the superior thyroid vessels, which will leads to hemorrhage. Okay. So second is bleeding from the muscular artery, and it will leads to, and so hemorrhage. So this hemorrhage can leads to tension hematoma, and manifestation of tension hematoma can leads to respiratory distress. So we can see this hemorrhage, extensive hemorrhage in case of complication of thyroidectomy. So this tension hematoma, and what is the management of tension hematoma is hematoma must be evacuated immediately. Okay, hematoma must be evacuated immediately. And second is respiratory obstruction, and it will cause laryngeal edema. Cause is anesthetic intubation, tension hematoma, and bilateral recurrent laryngeal nerve paralysis. Okay. So other kinds of complications is injury to other nerves. Here injury of external laryngeal nerve and recurrent laryngeal nerve, and also Horner's syndrome due to injury of cervical sympathetic trunk. Okay. And another complication is like parathyroid insufficiency. Why? Because we already talked about this vascular infarction of parathyroid gland, and accidental removal of parathyroid gland. Like suppose accidentally you are going to remove parathyroid during thyroid surgery. So what should we do? in this case we have to confirm this is parathyroid by Fosin section. After confirmed, we have to divide parathyroid in 1 millimeter segments, and these 1 millimeter segments should be transplanted into sternocleidomastoid muscles, and site is marked by, we can either mark by silk sutures या by the using of clips. And other complications are like thyroid insufficiency and thyrotoxic crisis.
तो दोस्तों मुझे आपको ये वीडियो कैसा लगा और मुझे कमेंट सेक्शन में ज़रूर बताइए, और आपको और कौन कौन से टॉपिक्स पे वीडियो चाहिए वो भी मुझे आप बताइए। और अभी तक इस चैनल को आपने सब्सक्राइब नहीं किया है तो प्लीज़ मेरे चैनल को सब्सक्राइब करिए, जिससे कि आगे आने वाले वीडियो आपको मिस ना हो। और हमेशा की तरह फिर बार बार आके देखने के लिए बहुत बहुत धन्यवाद। थैंक यू।